Greeting to all. You are welcome here today in this training session, which is designed as a purpose of a part of the training program for public health students, which is also designed to be as a part of the quasi-experimental studies, which is conducted in Saudi Arabia. So this training is based on the CDC field epidemiology manual, and also it is extracted from WHO national WHO manuals, which has an outbreak response handbooks. Our agenda for these sessions, it will exist on the definition of outbreak and also the steps of a field investigation, which is being considered as a core part of epidemiology and outbreak investigations, case definitions, classifications, and also how to identify or looking for further cases, case findings, and align listings, and also descriptive epidemiology as a first part of the study, since the epidemiological studies is depend on the epidemiological and investigations steps, which is include initially descriptive, which the data should be represented in matter of time, place, and persons. Analytical epidemiology, the next part of the studies, which is come after descriptive epidemiology. Control and preventions measure are the part also of outbreak investigations process, communicating the finding in three priorities, communicating with the health authorities, communicating with leaders, and also communicating with community. Regional case studies, we will have like some lesson learned from some of outbreak that has been occurred in Saudi Arabia, like MERS, COVID-19, Hajj and Umrah is also a case of we may have some of this outbreak which is being happened during the Hajj and Umrah. Career in field epidemiology, also like we are going to conclude and come out with who's supposed to be taking or carry out the field epidemiology or outbreak investigations, and also who's supposed to be as a part of this team. We develop and formulate a set of learning objectives for all of you at the end of these sessions. Everyone from this training should be able to define an outbreak, to distinguish between outbreak, epidemic, and cluster, pandemic, and implementing and applying the 10 classical steps of field investigations, construct a case definition, classify the case in matter of confirmed, probable, suspected, and also the ebullition cases, build a line list, and also perform the descriptive epidemiology, as we have said, how to represent your data in matter of ABKR for spots map, generate a test hypothesis. This is the first steps, which is come from the descriptive analysis, which is also reflects the overthought and also reflect the magnitude of the outbreak investigation team. You should be also able to describe the control measure and communicating findings and effectively communicating measures which it should be provided for the publics, and policy development in addition to communicating with the three priorities that is being highlighted before. Finally, you have to apply these skills regionally relevant, like in some scenarios, as I have just suggest these two scenarios as a lesson learned in Saudi Arabia. As we are going to start or initiate our training, we have to start, and we are going to start with the what is an outbreak, because Identifying the term of an outbreak, it is important to to utilize the all steps which has come out after outbreak happening. We have four main categories in epidemics as a general on epidemiology. Each one should be familiar with this. When we say an outbreak, so it's something different than epidemic, something different than clusters and the pandemics. And it has been originated with the smallest one. Okay, like in outbreak, it means that more cases of the diseases than expected in the given area or populations over the particular period. For each one of these terminologies, we have to make sure that we are going to describe time, place, and person. So it means that the irregular number or unexpected number of cases, it should be within a particular group of populations in a particular or specified time. When it means in a small group, unexpected cases in a small group, like food poisonings among some people attending weddings. So that is this is an outbreak because at the time it is within a particular time from Thursday to Saturday in particular population, those who were attending the dinner, and it is unexpected because we are unable to expect these types of food poisonings within our admissions in the hospitals. But when we jump to epidemic, think about the extended population and extended places. I mean, like geographical distributions. This is clearly more cases than usual. This is distributed over a wider geographical area. It's simple. It is something that is extended from the outbreak. When we go for the clusters, we are talking about cases also, but here we talk about an aggregations of the cases in an area or period, regardless of the whether it exceed the expected number or not. This is normally for the rare cases where it happens, so it could be happening at the same time, but it doesn't have a link for each other. Like one case is in city A, one case in city B, and another case is in city C. But there is no any link between the cases which is appear in A, B, and C cities. Pandemics, when we like mentions pandemic, so that is means we are expressing the number of the cases or the existence of the irregular cases in a different countries or across multiple countries or containment. Then uh, why field epidemiology matters? Why we are going or running after to look and investigate for any one of these set or model of patterns of the diseases, whether it is outbreak, epidemics, sporadics, cluster, or pandemics. We are going to do this in matter of the speed in responding to stop the transmissions, provide evidence, as we have said, descriptive analysis, descriptive studies and analytical studies both are help on generating the hypothesis, which is answer the questions of the outbreak or the questions behind. We are also running after to provide a trust. This is a matter of communications with three parties, whether it is healthcare providers, policymakers, or community. And it is also a big chapter here in our training about risk communications, how to contain the outbreak, how to manage the communications with these three parties in matter of keep everything in distance and also provide an environment for healthcare provider to perform their preventions and control measures. The first steps on outbreak investigation, it is confirming a true outbreak. How to confirm the existence of the outbreak. How to make sure this is outbreak or not. So to make sure we are in a real or true outbreak, we have to make and studies. This is studies that called comparative observed studies. In this case, we are going to make sure the existence cases exceeds than the normal or the actual or the regular number of cases, and rule out the epidemics. Sometimes we may get a news which it could be come from newspaper, it could be come from media, it could be even come from communities, like the leaders in communities, and they are declaring or raising that they have an outbreak. Here we have to make sure this is an actual outbreak by comparing these cases. Also, we have to make sure that to check the other sources of the detections, like contact the clinicians or physicians about the availability and the existence of the cases, like whether they are seeing the cases or not. Laboratories, those who are lab technicians, they may be also at the first line in detecting the cases, and also where there is a serial of lessons learned from those laboratories about, and COVID-19 is not away from this, because the first persons who announced the COVID-19 outbreak, it was a laboratorist or lab technicians. He raised that is there is a new strain and new types of the COVID-19, but no, in that times it has not been taken seriously. That's why the number of cases has been extended to different countries. Routine surveillance, this is the actual and the pathway, the accurate pathway, which is provided to address and to detect the outbreaks. Media, WHO, and government. Uh, as I have mentioned, in module 2, we are going to discuss the 10 steps of field investigations. These 10 steps in field investigations is being considered like the basics steps for any public health professional to be taken. And emphasizing all of you to understand and keep to memorize these 10 steps, because it's consists of a methodology on solving any outbreaks and epidemics exist. Okay, this it is 10 here because here we are adapting the steps which is come from WHO and CDC, but sometimes we may find this step is merged in 5, sometimes it's merged in 7 steps. That's why I'm requesting all of you to be understanding first what we have to do, in regardless the number of the steps. But simply, these steps, it started with prepare the field works, identify who's supposed to be take the role of outbreak investigations, confirm the diagnosis, taking samples and asking or looking after to see what is the diagnosis. These steps is mainly depend on the lab investigations, and determine the existence of outbreak. This is our steps on how to make sure we are in true outbreak. And here we are going to do a study about the comparing of the same day, I mean like existing cases, compare it with existent time, place, and persons, and make sure it is an irregular or unexpected cases. Identify the count the cases, go to field and bring out the number of cases. To go and bring the number of cases from the field, you have to provide case definition, identify first who's supposed to be counted as the cases, and also systematically case findings. Tabulate by times, place, and persons, starting putting or presenting your data presenting the data, it should be in a phrase or initially in matter of the like tabulations by time, place, and person. This should be from the control considerations to the communications. It means identifying the reasons, I mean the causes, why the outbreaks exist, up to provide this informations or the findings to the three priorities as I have mentioned. So consider early control measures, regardless whether the cause agencies exist or identified or not. Develop a test hypothesis. Here we are going to start our analytical study. Analytical study is started by developing the hypothesis test. The hypothesis test should be answer the question of what is the cause, what is the source, what is the others existence, assisting factors which is increase the possibility of the cases and how the diseases are transmitted. Plan additional studies also to identify others remaining uncertainty, any undetected rhythms, and also implement and evaluate the control measures. This it should be within the whole I mean like existence is spontaneously within the all steps. Communicate the findings, communicate these findings with healthcare providers, leaders, community leaders, and also within the all communities. The steps early run in a strict order. Step 2, confirm the diagnosis. As we have mentioned, these steps is mainly depend on the diagnostic test or laboratory test. Step number 6 to 9, it is control measure. Can it's an often should beginning before every step is finished. So that is when it is spontaneously. We are not going to start. Sorry, we are not going to wait up to the end of the outbreak investigation and start our preventions and control measure. Preventions, the golden rule we should take is the prevention measure. It should be exist at the time we start our outbreak investigations, and then the real investigations look back, new lab result or interviews can be sent you back to the to define the cases definition. So case definition is flexible. Case definitions, it could be changed because the main purpose of the case definition is to help us to detect and identify more and more cases. Here we have a quick check. A hospital lab report a sudden rise in a positive stool culture. We're going to look here who is uh, like raising or detect the outbreak. Here the outbreak is detected by the laboratories. One review. This is serious. Exactly, it was the switch to a more sensitive testing method, which is no change in patient symptoms reported, and this is the most likely, whether it is a point source outbreak, a propagated an outbreak, a sort epidemics outbreak, or an endemics diseases with forms. So this is appearing as a raised tracks of changes in laboratory method. It is not through increase in illnesses. These examples or the quick checks, it's I read it here because to to show you that sometimes not all the existence irregular number of cases it could be considered as an outbreak, and that's why the first step in outbreak is very important because it is all the other steps is depending on the first step, which is it is also independent steps. It could not have any link to the other steps. Like confirm the existence of outbreaks, it means to make sure that this is a true outbreak. So that's why it's very important. The case definitions and case identifications Case definitions is mainly describes the cases which is supposed to be counted in our investigations. It is important to develop these case definitions because it helps us on focus and retrieve, like go through and go straight forward to our cases under our study. So it should be include the conditions, the time, and the place. You can add whatever you want to add. You can add tribe, you can add occupations, and you can add marital status, whatever you want. But finally, you have to make this case definition sensitive enough to detect and to pick out all the relevant cases. Conditions, it could be it should be clinical symptoms, signs, laboratory findings, whether it is probable, confirmed cases, confirmed or appealing. Time, the period, and it should be exactly the period of the outbreak to be sensitive to highlight the cases. Setting where the places setting where the conditions occurred, like is it in a town X or in a town Y or in town P. Finally, cases should be classified. Whatever we picked in our study or in our outbreak investigation, it should be whether it is confirmed cases, probable cases, unsuspected cases. This is the classical classifications, but you are free to provide whatever you want as a classification. You can do suspected cases. You can also apply or add EPLINK cases. You can add a CIMIC, whatever you want. It could be because this is a rule that is you are going to use to come out with the final classifications of the cases. The most classical classification is confirmed cases, and this is depend mainly on the laboratory result. Wherever match the laboratory result or existing or isolating the cause agents, like in measles, any cases, uh, uh, any cases results are positive on identifying or isolating the measles virus, it will be considered as a positive cases. Probable, that is meets the clinical epidemiological criteria, but lack lab confirmations. Okay, so that is means all the signs and symptoms of the diseases or conditions exist here. So in this case, we can say a probable. Probable, it means look like, except no confirmations from the lab. Suspected cases, we can say a suspected cases when it is made as a subset of the criteria. So that is means probable is something higher than suspected. If we have a 10 signs and symptoms of the conditions, in case of we have the 10 signs symptoms of these conditions, so we can say this is a probable. But when we are going to suspect when we have a less number of signs and symptoms. I think it's clear now here. We are going to build the case definition. As we have mentioned, case definition should be built to be sensitive enough to detect all the suspected probable cases. We are not going to go for confirmed cases, because confirmed cases is mainly depend on what? It is mainly depend on the lab confirmations. Here we have a scenario over 3 days. A village clinic sees an unusual number of patients with fever, rash, and several report also listens content with each other at the weddings. Here we have time, place, and persons. Okay, the condition was the clinical lab criteria would be required. So why we are going also to take how we can also come out with the lab confirmations in matter of selecting the specimen modes and collecting the like the samples, time, what period, and places. Do you restrict to wedding attendee, because only one those who are attending the wedding will be considered here. Case finding, line listings, and active surveillance. Case findings, where it could be either by passive or active search. Line listings, the way that we calculating all the cases, and active surveillance is the way that we running out and looking for the cases. The first questions we should ask it is where do cases come from? So public health agencies, surveillance data, and notifiable diseases report is the main routes and main sources of the cases. This data also could be come from the medical record, from the hospital, institutional record like prisons, schools, workplaces, or attendance log. Special active surveys of also populations at risk, like the surveys that is conducted as an active search to identify. Active case findings, it means investigators should go out and like figure out the cases. It's on a proactively searching for additional cases beyond the routine passive routine reportings. We are not going to sit in office waiting for the cases to be announced. This is raw cases, and this is what we call it the line listings. It means the organized the table which is consists the basics information about the cases, and it should be including time, place, and person, in addition to the lab result, because your lab result is very important, because it's going to help on classify the cases and put it as a matter of the case classifications and case findings. Ascertainment bias. We are also like in a potential to commit some bias, and it has to be accounted when we are going through outbreak investigations. What we have to consider or count is relying only on the hospital admissions misses like milder community cases. Here, like we are calling for active search, we have to go out and look in communities, schools, whatever. Even in hospital itself, we have to go and check the records. Media attention can be prompted over also reporting from the nexus, but an affected person, sometimes the panic, it may affect some of those community member, and they may be also reported other cases in pseudo manners. The solution is search multiple independent sources and also keep the cases definitions constant for everyone screening. So that's why the case definition it should be sensitive, at the same time it should be simple, at the same time it could be also uh, like recognize in the method that is help even community to identify, also report the cases. Developing descriptive epidemiology, as we have mentioned, this should be in matter of time, place, and persons. And finally, we have to represent data in tables and figures, and this should be coming after collecting the all informations, gathering the informations from the cases. This information should be exist for categories, identifiable information, which should sometimes we need to know about names, telephone numbers, address, and whatever, and demographics data, which is including age, sex, and others, marital status, or whatever, economical levels, and so, and clinical informations in matter of signs and symptoms, and so, and epidemiological, other epidemiological information in addition to environmental factors. Then here, the first recognitions of the the outbreak patterns is a point source. Here, like when we talk about food poisonings, the last scenario we have explored. This is a single sharp peak within one incubation period. All the people attending the same weddings at the same times, and they develop the sign and symptom within the days. Here, in a few days or sometimes it's a few hours, the cases come out. That's what we call it a point source or common source patterns. The propagated pattern of epidemics, it is usually describes the person-to-persons infections, and the classical examples of these types of propagated epidemic curve, it's measles, because we know that is measles, it's high secondary, so it has a high secondary cases rate, and this is exactly appearing here because now we have three peaks, and each peak has a relation to the previous peaks because the transmission is going to be transmitted from group to the other groups. Another or the third types of the epidemic care, it's continuous, intermittent, common source. Here you just think about the uh, outbreak in London, which is being highlighted by John Snow. So here the people supposed to be exposed to a one source of infections for a long period of time, like uh, water pump source stream in the river, or a part of restaurants, which is being affected by hepatitis A or whatever. So here, that is means populations are exposed to the source of infections for long period of time. One important thing that it should be important in representing the cases in outbreak, it's a spots map. Like we are going to describe the cases in matter of place and persons. We should identify the map and put spots in this map to show that what is the where the distributions of the cases and who appear in each area in this distribution. This is important because it is giving the clue of the transmission of the cases. Like when we see the cases started from A running to B, so that is means we have to go to A and make the containment or preventions and control, because A it's been hypothesized as the a part of the infection control, also the infections sources to the other part. For analytical studies or come out with for hypotheses, very important to identify the attack rates. Attack rates, it means that the upper or the intensive of the microorganism on making diseases. And another way, how the virulence of the diseases. The attack rate is usually calculated as the number of the cases among those who are exposed. The total number should be divided to the total number who AIDS. I mean, like number who was getting disease over those who are attending the weddings. Like here, when we calculated the attack rates item wise, like in chicken sandwich, there is 80 those who are AIDS, the chicken sandwich. And the total numbers of those who are attending the weddings are 120. So when we divide it, 80 over 120, it means that is around 65% attack rates, and attack rates among those who are ill, among who are ill, is of 72. Attack rate should be calculated among those who age and among who does not age, because finally we have to come out with the odd ratio as well. and this is as a classical a scenario. It shows how to come out to identify the patterns of the diseases. As an epidemic curve shows several distinct wave of the cases. So that means we have a multiple waves and multiple peaks. Here directly you have to go for propagated because, as we've mentioned, secondary cases comes as waves. So that means this cases is transmitted from person to another person. Generating and testing hypotheses, I have mentioned earlier, it's come mainly after it's come mainly after gathering and analyzing the data. How we come out with this? We come out with this with cohort versus case control studies. Both together they may be a part of identifying the hypothesis. We have to conduct cohort studies and case control studies. The answer that I want you to memorize is, in outbreak investigations, we are going to conduct several types of epidemiological studies. It started with descriptive studies, descripting or describing the cases in matter of time, place, and person, and also analytical studies which is exist in cohort and case control study. We have to come out also with the odd ratios, and in odd ratio we have to do 2 by 2 table or contingency table. In these tables we are like seeking to identify the foundations of every associations measure. Associations, it means we have to identify the odd ratio among those who are exposed and those who are unexposed, those who are AIDS and get L, and those who are not AIDS and get L, or and so on. So by this, we are going to know how intensive and how is serious and how various the disease. The attack rates, relative risk, and odds ratio are the three main analytical studies and analytical significant tests which should be identified. Attack rate is normally calculated as new cases over the whole populations over 100. This can be stratified by exposure, whether they are exposed or non-exposed. Relative risk is how many times more likely an expected person to fall ill versus those who are not expected. Like disease could be come out with like the answer should be 4. 4 it means what? 4 it means those who are exposed had a 4 chance to get the diseases than those who are not exposed, and this is also giving strengthens and accepting the hypothesis that you have been raised on the aqueous agents or whatever. Odd ratio, it approximates relative risk when the disease is rare, like standardized measures in case control studies, as 95% confidence that excludes like one suppose a statistically significant association. So that means each one it has the equal chance to have the diseases. The cohort study, this is, it could be consist when like taking a time on identifying. We need times to identifying the or answering the outbreaks and epidemics questions. It is here like when we said in case of interpreting the odd ratio, when the odd ratio is equal 8 at 95% confidence intervals, this is excludes 1, like AG3 0.2 minus 22.6. A case control studies find this is odd ratio for conceptions of the particular dairy products. We can say whatever the types of food items that is being distributed or it has been existence in the study investigations, and this is indicating strong statistically significant association between the exposures and the illness. So it means that all those who are exposed or AIDS, the item, they are get and develop the diseases, supporting or the prompt removal of the products even before every confirmatory studies is completed. Sometimes we can like go through and taking action even the lab confirmations does not exist, depend only on the statistic analysis. Here we have like a supportive scenarios in case control study of suspected foodborne outbreak. The odd ratio for the 18 particular sources is 1.1, which is being range and lay on 95 percent confidence interval of 0.6 dash 2.0. So the best interpretations is strong evidence the source cause illness, no convincing evidence of association. It means no any other investigator, other exposures, and so on. So the P is the exact source and correct source of the answer of this scenario. Implementing control and prevention method. Make sure that, as I have mentioned, preventions and control measures should be existing all steps since we start the outbreak investigation. So, but here we have two categories of interventions: direct at the sources or directed at the susceptible persons. Sources, it means also already been considered as cases susceptible persons and person who are at risk, like those who post exposure prophylactic, targeted vaccinations, and barriers precautions like mask and so on. We can also look and consider this is during the COVID-19, since we have a direct control measure for those who are already assigned as cases and a directed measure for those who are in risk to get the cases and so on. Still we are stress and focusing on starting the prevention control measure even before identifying the cause agent. So that's mean acting before the investigation is completed. It means that it should be within all the steps. So hepatitis A in a child care setting. So this is a scenario, and it is existing like how to initiate your preventions and control measure within only signs symptoms being detected or initial diagnosis of the diseases. So that is means it is a good clue, because when we are suspect measles, so that is means we know at the time that we know how the disease is transmitted, it is the time that we have to start putting our plan for preventions and control measure. Communicating findings after you gather your information in matter of time, place, and person, and also the analytical studies that is being conducted. You have to come out with these communications findings. Establish communicating plan at the start of the investigation. Who's supposed to be a part of your intentions to get your communications? Okay, and designate a single also speak persons who is supposed to give the whole information about the outbreak. Provide timely oral briefings, like every day you have to come out to people, tell them about what is happening yesterday, what we are going to do tomorrow, and what is expecting from their side in matter of prevention, control, and so on. Like what is happening during the COVID-19. Someone they speak in person from Ministry of Health used to come every day at 3 p.m. In the main canal of Saudi, giving brief about the disease, asking people to what is supposed to do tomorrow, and if there is any new policies like wearing mask, lockdown, or whatever, it has to be also announced within one persons, like to unify the communications. Publish also rapid in public health bulletin, so that is means you have to come out with a feedback for those who are already in the field and so on. Here we have in communication risk, we have risk communication, we have a plan for the checklist. Who is a single designed person? Dr. Adam is the one who's supposed to provide and release everyday informations, which is stakeholders need to be oral digits like Minister of Defense, Minister of Education, Minister of Finance. Those all supposed to be with us in our communication. Who receive the preliminary written reports before the field team departs and so on. So this is like a list which is organized how we are going to communicate our findings, because this is a very critical point in our pregnancy. Otherwise, people they may get panic, and people they may also develop rumors, and these rumors is as another risk and diseases which is could make a barriers on providing and retrieving and also bridging the preventions and control measures to community. Private bulletin save lives elsewhere. It means releasing on times informations. The appropriate set of the informations is very important to manage the panics, manage rumors, and also helping on providing or applying, implementing prevention control measures. And this is could be through CDC, WHO, Ministry of Health, local national Ministry of Health, local authorities. And for mass gathering events like Hajj, rapid alerts help also belongers home, coming from different countries. So we have to release these bulletins to them before coming to get ready on how like number of vaccinations, prevention control measure, precautions, everything it should be released before to make their Hajj performance easy and also save others' lives during the Hajj and Umrah. Here we have the regional cases studies in our module 3, like region zoonotics and outbreak. Here, we are talking about different type, endemics to Arabians Peninsula since 2012, and here is 4 cases, 9 cases confirmed, also cases reported, and it could be moderate. WHO overall risk assessment, the national and regional level. This is being considered as a cluster of cases because the number of the cases is scattered, and also there is no link in between all these cases. How this is happened? This is happened during the treatments of the camels within those who are living in nomads and rural area. So primary animal reservoir often shows normal only and mild signs of the infections, and those who are being in contacts, whether it is direct or indirect, with the camel products like raw milks and urine or others, contact with the discharge or secretions which is come from the camel, and those who are already also with a contact with the human cases, those who are healthcare providers. Most human cases has camel exposure, as this is as a part, and this is assured also. It has been proved during the outbreak. Sure, the human to human, it was very rare. Human to human transmissions, it was very rare, and the community spread is unlimited, but the nosocomial transmissions, it was very high, and this is appear very clear during the outbreak within the healthcare workers. Some mass gatherings outbreak risk, we talk about 1.6 million pilgrims in 2025 from coming from we can say all over the world. You can say 100% countries represents. Those are all together come out in one place. What are you expecting? We are expecting exchanging language in addition to exchanging disease also, unless we have restricted precautions for preventions and controls. The most common is respiratory infections, foodborne disease could be exist, and also genetically related meningococcal diseases, especially for those who are coming from meningococcal pulse countries, and growing use of like syndromic surveillance, the genomics, multi-pathogen surveillance, and restrictions. In 2024, UMRA links meningococcal clusters has been detected genetically. This distinct, but it's related to invasive meningococcal disease cases appeared among returning UMRA pilgrims. Foodborne also, it's been measured and detected, and here also we have a classical examples of how to identify the infected items, which is food items, look like the strongest candidate for the outbreak vehicles and why. Here, like we have to calculate the relative risk, because the high relative risk, it means the high probability of developing the disease. Here we have the data decisions, like we have to calculate the relative risk in each one. Here the grilling chicken attack rates, it was 23% for those who are eats. Those who are non-eaters, it was 4%. So that is means within those who are not eats the chicken, there is also still 4% develops diseases, and this is also may strengths the hypothesis of the aggregated chicken attack. And aggregated chicken items is responsible for this attack. So strong single pointing to the chicken at likely the vehicle. Here we have other steps, bring it together. It is the chicken had been prepared off sites by shared supplier serving, so we have to look for the history on how this food has been prepared here, and what is the other ingredients that exist in these foods. In this way, we can come out with what is the exact suspected or candidate item which is responsible for the transmissions. In module 10, we are going to explore the public health workforce and career pathway. It means we are not going to work alone in outbreak investigation. Still, we need some others in our fields, in our communication networks, to help on solving outbreak investigations dilemma, and also to support in prevention and control measures. In field epidemiology, these training programs, like since in 1989, Ministry of Health in USCDC, Saudi Arabia, King Saud University, and field epidemiology training programs. This is they are graduating a lot of candidates, those who are ready to help on outbreak investigation, and now they are practicing field epidemiology. So that is means what? That is means any types or any mode of outbreaks, they will be as a first line to practice their own. And this is another way of why do we conduct outbreak investigation? Sometimes we conduct outbreak investigation for the educational purpose. So getting involved early, also practice of responsible antimicrobial stewardship, and also seeks interdisciplinary learnings across clinical labs, machinery, and environmental health. Like this is a way that we develop our own health, being invades and uh, exist in our investigations. Here, this is a pathway from student to field epidemiologists, like undergraduates and PhD studies, entry-level public health roles, Saudi field epidemiology trainings program. This is a diploma 2 years. Senior field epidemiologist. This is after getting like 5 experience on outbreaks investigations and working with epidemics. So will be as epidemiologist. And you do not have any, or you are not in need to be seniority to contribute. So anyone he can contribute in with either a little level of experience, with a solid level of experience. Also, public health students can begin contributing early in their career well before reaching senior positions. What we have done now as a part of outbreak trainings program, it will also being considered as the first part of your contributions in outbreak uh, control or outbreak investigations. The one important thing that we have to go on it is the modern terminology in outbreak investigations. Why I highlighted this? I highlighted this because the terminology in outbreak investigations is getting, like modifications, and it is also getting updated. And people used to change some terminologies because of the they need to have these new terminologies in matter of like a sensitive descriptions of the terminology. And here I intended to put you also in the recent and the moderate terminologies in compare it with all the uh, new terminologies. Uh, there is some vocabularies that has been shifted since 2022, like professional outbreak reports now use specific or standardized vocabulary shift. When we say a case definition, so that is what it means we are talking with etymology language. So that is the same things if we are talking on Japanese language, German language, or English language. Case definition is a case definitions. It is operational definitions. Okay, this shaped mainly by WHO, WHO, CDC, and others. So using the current term single fluently with the presence, the practice, and keep reports interpretable across the agency. So that is means when we talk about a single language, so that is means makes everything is easier for those who are participating in this field. Here we have some terminologies in regard to surveillance and detections terminology, like applied interventions epidemiology. This is surveillance detections. Here, like increasing use in place the field epidemiology. Okay, this is reflecting uh, move away from the term of the colonials, military origins, or whatever. So it means a recent use of these terminologies. Epidemics intelligence. This is also one of the correspondence of the surveillance or detections. If I say epidemic intelligence, so that is means what? That is means I'm talking about the highest level of methodology which is aimed to conduct a surveillance or detecting disease. This is the current WHO and WHO umbrella terms for the cycle of surveillance, collecting, analyzing, verifying, and communicating the information about the disease detections. Event-based surveillance. It's a way of also surveillance. When we say event-based surveillance, EBS, so that is means organized collections of surveillance. Those all together come as a surveillance. Indicator-based surveillance, that is means we talk about surveillance and detecting of the diseases. Public health intelligence. Public health intelligence, it means what? Public health intelligence, it means surveillance systems or detection of the disease, single verification risk assessment response. Thus, like we are also describing the surveillance and detections. I'm putting you here because you might find these terminologies, and these terminologies, I don't want to take it you away of understanding the main purpose and the main and the direct approach of this. When whenever you find these terminologies, it is exactly surveillance and detections in a modern and sophisticated way. Collaborative surveillance. Collaborative surveillance, it means that we are talking about the surveillance and detecting of the diseases in matter of integrating others, like those who are in the same field of epidemiology, those who in community, those who are leaders as community leaders or supportive leaders or collaboratives from other parts of the community. Genomics and transmissions. There is transmission matrix terminologies. This is also the way that the disease is transmitted. Wherever we see, that means we are talking about the mode of the transmissions. Okay, it could be coming as a genomic epidemiology surveillance. It could be variants of concern, VOC, or variants of interest. So still we're talking about the transmissions and suppositions. Wastewater-based epidemiology. It is also genomic transmissions of the diseases that standardize its surveillance, but here it is modified only with a a wastewater based epidemiology. Effective reproductions number. This is like our reproductive numbers, the number of the cases that is come after the secondary cases. Like if we have a one case of measles, how many cases we are expecting to be transmitted direct from this origin, the origin of these cases. That's what we call the reproductive number. So it means that the genomic transmission, it means that the mode of the transmissions of the diseases. Super spreading events, this is mainly describing the virulence and the effectiveness of or the power of the microorganism on exploring and increasing the numbers of the cases. We have another types of the modern terminologies in regard to responses or coordinations and preparedness. Okay, this is like incident management system. When we say incident management system, just think about how we can respond in coordinate with others, intersectoral coordinations, risk communications, community participations, community development, community orientations, all together. That's what all in one. It could be standardized commands, structures like incidents managers, operations, planning, logistics. That is expected from the modern response report. PHEOC, this is a Public Health Emergency Operations Center. Before, it was called like Emergency Response Team or Epidemic Investigation Teams or Response Team, but now we can say, or we can call it RCCE. IHR 2005 core capacity, GEE, that's what we call it international health regulations core capacity. Those who are belong to international health regulations team, those who are responsible exactly on responding to outbreak or pandemics or providing support, especially even in outbreak. Sometimes WHO can support the outbreaks in countries, even though it's not a pandemic, but still, if I seek their support or WHO found that this country is not competent enough to overcome and to contain this an outbreak, Still, WHO could provide technical support for this. Um, Others like quadriplegic diseases like X disease is consist of some of the UN agencies that is responsible on providing the response for such types of the diseases. Writing protocol, it means writing your initial plan on how you are going to come out with this outbreak. And this is the initial part of your outbreak investigation, especially before providing your like field responses using current standardized terms rather than the older or informal equivalents make the protocol immediately eligible to reviewers, funders, and also partner agencies. Like I'm telling this is because we need to use the moderns and the latest terminologies in epidemiology. Like instead of to say case definition, you can say operational definitions. So this is more sound enough to be taken as a professional and also reflect the professionalism of those who are providing this protocol or the reports. This is a quick examples of a scenario. I'll keep it for you to enjoy it because in our post questionnaire you might also face such types of this. So this is also as a good practices for you. Here we have some summary for our session today. Outbreak, it is confirmed by comparing observed versus expected cases and rolling out the pseudo epidemics. This is a most important steps, like confirm the existence of outbreak. Make sure it is true outbreak, not pseudo or false outbreak. And this is by comparing the same data and matter of time, place, and person, and make sure that is an irregular cases or unexpected cases within the particular time, place, and persons. The 10 steps of the field investigations may run concurrently. Don't wait for the step 10 to start controlling the outbreak. So outbreak control prevention measures, it's going spontaneously. It means it's concurrenting. It means within all steps. The time that you know how the disease transmitted is the right time to start your prevention and control measures. A good case definitions as systematic cases findings underpins every later analysis. Case definition, operational case definition should be sensitive enough to detect all the cases. Okay, the epidemic curve also shaped a powerful, fast clue to the mode of the transmission. When you come out and represent your case definition, sorry, your epidemic curve, it will give you a lot. Like you are professional. When I told you my epidemic background says point source, a lot of and several types of information should come to your minds. That is a single exposures. It is coming and develop it within a few days or hours and so on. So it is give it a story. So a story it's come directly from the epidemic curve. And also the types of the analytical studies that and the studies, epidemiological studies that is conducted, and what is also a specific test it could be used to come out with or to prove the hypothesis, like relative risk or odd ratio, communications and communication risk also as a matter, and also the lesson which is learned from the Saudi Arabia in matter of COVID-19 or MERS and so on. Here we have our sources. It was from CDC epidemiology manual, training manual of Saudi training manual, WHO guidance, and also TEFNITS or MFNITS regionals and global network of epidemiology training programs. I have kept this is at the end of our sessions, because it should be treated as the first part of our field investigations. We have to consider risk communication during outbreak investigations. As we know, that is when we have no a plan on how to communicate or how to risk communicate. So that is means we are expecting rumors, we are expecting panic, and we are expecting also refusals, malinformations, and so on. And this is also, it will draw back our failed steps. So what is risk communications? Risk communications is the real-time exchange of informations. Right time for provide right informations for right persons or right community. Recommendations and also an opinions in between the official experts and people facing the threats. Could be or should be within community, healthcare workers, and policymakers. Okay, the modern practice pairs, which is community engagement, risk communications, and community engagements. So communities are also equal partners, not a passive recipients of the message. Equal partners, we have to give them the amount of the limit information, which is help them and us to perform our investigations. RCCE is a source for capacity under the international health regulations, and it has the policy steps to be released, and a part of also the WHO Health Emergency Preparedness index. Communication runs alongside every steps. Started from step number 1 to 10, we have to consider the communications plan, risk communications plans. Communication is not a final report. Even within announcing there is an epidemics or an outbreak is a part of communication. So that means we are talking about system number 1 and 2. RCC runs in parallel with every steps of the field investigation. This is a core of our lessons in risk communications within outbreak. There is a core principle of effective risk communications. We have to trust buildings, build a trust between you and community, health authorities, healthcare workers, and leaders. Transparency and honesty. Give the exact information. Don't lie, because when you lie and the community believes that you are lying, you're not going to accept any trust. I accept any information from your side. Speed for resistance is fast. Empathy and solidarity also is should be exist. Community involvement. You have also to deal with others, people who may be influenced in community, to give some of this or to be a part of our communications. Coordinate, like one voice. You have to make one person to provide or release this information to the community, channel and message telling. You have to tell this message or to design this message carefully before you release this message to the community. Here we have some lesson learned from Saudi Arabia, MERS and COVID-19. WHO launched a major public awareness campaign, and also in COVID-19, WHO used CERC guidance in Twitter strategies. The rate useful by 72% and satisfactory by 74% of the surveyed users. They are satisfied. That is the way that Ministry of Health release the information is quite enough for us to be aware about what's going on, and also it is in consistency with what is already the words shown, because people are not going to depend only on your information which is released in your national channels. They have their own searching engine, like ChatGPT, Google, and so, and even the international TV as international channel to follow up with other countries and knows. When you talk about the cause agents and you say the cause agents of COVID-19 is a bacteria, so that is means you are lying because all over the world people knows that is the cause agents is a virus which is responsible for the COVID-19 and so that is why we have to design carefully the message. WHO Asia Mediterranean regions EMRO also has a core responsibility on providing or releasing the bulletins with the outbreaks informations, and this is like we can say it is mainly for the countries and states to be aware or to be aligned with what's going on within the countries. This is frames community engagement as a fostering equal partner relationship across the entire emergency cycles. Don't exclude, don't avoid community within your outbreak investigations. You know, even we cannot go for field investigations unless we get agreements from the local communities, because finally we are going to work with the community, so you have to get their agreements, their acceptance before starting, and within, after and within starting or conducting the outbreak investigation, still we need to have their support in the field. WHO also seeks these communications within the monkeypox when it has been started, Ebola, and I have also an experience of working with the community in communications and prevention control measures during Ebola crisis. This was in 2025 in West Africa. Here we have some discussions. Also, we can take it as a whole message for you. If you were designing RCCC plans for suspected foodborne outbreaks in university camps, which is the 7 principles which would be hardest to apply in the first 24 hours and why? Like the same 7 principles applied at every scale from single country Minister of Health to the multi-agencies global frameworks like building RCCE capacity before a crisis is what's make it work during one. So for communications, very important to have someone within the outbreak investigation team to be responsible for communications. And this one is not important to be a public health officer or epidemiologist or so on, but it is someone who has the ability and the skills to be a good communicator, and also he has a solid and a concrete backgrounds about the diseases transmissions and so on. By this slide we are gone with or through with our session for today. In your hand, this is the references that it has been included, as I have mentioned earlier in my initial part of these presentations. I thought and inform you that is we extracted this literature from different parts, including CDC, WHO, and even the national literatures and reports from Minister of Health, Saudi Minister of Health. This is our linkage to CAB assessment, so it means how to start putting or framing out the outbreak investigations in matter of knowledge, practices, and providing effective communications. Thank you very much, and I'm glad to have you all in these sessions. I also appreciate and I mean thanks a lot your patience to follow this detailed presentation. I hope every one of you gets the exact benefit of this training. And I am also waiting because I'm going to share my all details, email, phone numbers, physical office, and I'm ready to like receive any inputs from all of you and any one of you like seeking any type of support. I'm ready to provide this. I'm not forget to give my introductions, but I intended to keep it at the end of these presentations, as I am Adam Douria, Assistant Professor in King Khalid University. My field in public health, I have a PhD in public health, and also my specialty is epidemiology. I have 13 years teaching in public health, and I have a field works experience with National Minister of Health, Federal Minister of Health in Sudan, and also I have an international experience working with WHO. I have been assigned as epidemiologist in epidemiology of poliomyelitis in West Africa, in Nigeria, part also of CDC, Center of Disease, US Center of Disease Control and Preventions. I participated also in 2015 on Ebola crisis in West Africa as also epidemiologist after or post-epidemics evaluations for Ebola and routine immunizations program. Thank you very much, and I wish a best for all of you. Good luck, and see you later. Thank you.